I would expect the session to be an interactive one and would request your active participation so that the learning becomes more effective. So, can you please unmute yourself, or you can type in your chat box. You have already dealt with the WHO analgesic ladder for cancer pain management. Can someone unmute and talk, or type in the chat box what is the WHO analgesic ladder? What are the steps involved in WHO analgesic ladder? No comments? No responses? Eye mouth? Yes. WHO analgesic ladder has 3 steps. Yes, the WHO analgesic ladder for pain management has got 3 steps. Which are the 3 steps? Step 1, step 2, step 3. 3 steps. And what is step 1? So based on the intensity of the pain, thank you all for the responses. Based on the intensity of the pain, the WHO analgesic ladder, slide please, has got 3 steps. Step 1 for mild pain. So step 1 of the WHO analgesic ladder includes non-opioids plus or minus adjuvants. And if the pain is increasing and persisting, then we prescribe with step 2. The step 2 of the WHO analgesic ladder includes opioids for mild to moderate pain plus or minus step 1. And for more severe pain we go on to step 3 of the WHO analgesic ladder. And the step 3 of WHO analgesic ladder includes opioids for moderate to severe pain, plus or minus non-opioids, plus or minus adjuvants. So I understand you have already dealt with step 1 and step 2. Can someone tell me which are the step 3 opioids commonly available in India? You can either unmute and talk, or you can type in your chat box. What are the step 3 opioids?
In Bangladesh, we give the pethidine, morphine, like
Pethidine, morphine.
Yeah.
Okay, thank you. Thank you
Actually,
for that.
fentanyl is one of the opioid.
Fentanyl, okay.
Yes.
So we have responses in the chat box also, which states that morphine, methadone, yes. So thank you all for the responses. And the step 3 opioids include the commonly available step 3 opioids in India are morphine, fentanyl, and methadone. Yes. So today we'll be talking about the step 3 opioids. So next slide, please. So we'll be proceeding with patient stories. So we have a patient scenario where a 56-year-old male who presented with carcinoma of larynx with severe pain, scoring around 10 on 10, and which was a sharp, not radiating kind of pain around his neck. Since last 2 weeks, he is in pain and is unable to sleep due to this. Suppose such a patient comes to your OPD, how will you manage this patient? So we have the pain score, we have the type of pain presentation, and the patient has come to you. How do you manage it? Any responses? So the severity of the pain or the intensity of the pain is 10 on 10. The scoring is 10 on 10, which indicates that it is severe pain. What
We
does that
can-
indicate? Yes.
As we can use a step 3 ladder,
Yes.
strong opioid. Like
Yes, very good. Thank you for that response. So that is an indication that the patient is in severe pain, which means that step 3 of the WHO analgesic ladder would be the preferred drug of choice. So yes, so we'll go with the step 3 opioids. How can we go about? So the patient has presented with severe pain, 10 on 10 pain, where we need immediate relief to the patient. So what can be done for this? Any suggestions? How many
Can you
of you
repeat
are
again?
sorry?
Can you repeat, please? Again?
So, so this patient has presented with severe pain, severe 10 on 10 pain. So we want an immediate relief for this patient. So is there some way where we can give the patient an immediate relief? How many of you are using opioids? I would request all of you to on your video, please, so that I can see you.
Please on your videos and have an active interaction, please.
I'm from Bangladesh and we use opioid by according doctor's order, not any health practitioners. So at first we need to inform doctor, and if the doctor give opioid like morphine or pethidine, we can give this drug.
Oh.
But without prescribing, we cannot, in Bangladesh, we can't give opioids like morphine or pethidine.
So, yes, so you're right. But suppose a patient comes to you in this condition, what recommendations can you give to the doctor? Like, you are the people who are the connecting the doctors with the patient. So you will be the best one to assess the patient. Suppose such a patient come to you and if the doctor is not available in the table, like in the OPD, and you have to give a recommendation. What recommendation would you suggest to the patient? I mean, to the doctor. So there is a procedure
Yes.
called intravenous morphine titration. Next slide, please. So this is a procedure that we do in our outpatient unit, where when the patient presents with severe pain, we can bring in immediate relief to the patient. So how do we go about this procedure? So the 1 ampule of morphine contains 15 milligram of morphine. So this ampule is diluted with 9 ml of normal saline and a 10 ml of diluent is made in such a way that each ml of the diluent contains 1.5 milligram of morphine. That is, so 1 ml of morphine diluted with 9 ml of the diluent, and such that 10 ml is made, and each ml of the diluent contains 1.5 milligram of morphine. And this 1.5 milligram of morphine is given to the patient every 10 minutes. So the patient is given 1.5 milligram of morphine every 10 minutes. And in such a way that either the pain comes down or the patient becomes drowsy. So whichever happens first would be considered as the endpoint of the titration. So next. Yeah. So as I mentioned, 1.5 milligram of morphine is given in 10 minutes interval to the patient. And what do you think is the immediate side effect of morphine? Anybody has any idea what the immediate side effect of morphine is?
Maybe itching.
Itching. Everybody
And,
agrees?
Hallucinations.
actually,
Hallucination,
Constipation.
constipation. Yes. So I'll go with Angela. The immediate response or immediate side effect of morphine is emesis or vomiting. And anticipating that, we usually provide the patient with injection metoclopramide 10 milligrams stat before starting with the titration process. So 10 milligram of injection metoclopramide is given as stat, and after that the titration process is started. And when we do the titration, 1.5 milligram of morphine is given at every 10 minutes interval in such a way that either the patient has satisfactory pain relief or sleepiness. Is that whichever happens first would be the endpoint of the titration. So to make it clear, this is the process of intravenous morphine titration. Suppose a patient comes to you and with severe pain, 10 on 10 pain, and you think that the patient needs intravenous morphine titration. You have diluted. First one would be the pain assessment. You have already learned the assessment of pain. The PQRST of the pain needs to be assessed. So the pain score needs to be assessed and we check with the vitals. Then injection metoclopramide is intravenously is given to the patient, and now the ambule is being prepared. So the 1 ml ambule of morphine contains 15 milligram of morphine. So a dilution of 10, it is diluted with 9 ml and a 10 ml dilution is made such that each ml contains 1.5 milligram of IV morphine. And this 1.5 milligram of IV morphine is given in every 10 minutes interval. So before starting the trial, check the vitals. The pain score of the patient is recorded. So in this patient, the trial was started at 10 a.m. The patient's pain score was 10 on 10 and the patient was not drowsy. And 1 dose or 1 ml of injection morphine was given. Wait for 10 minutes. Reassess the pain score. The pain score became 7 by 10. See if the patient is drowsy or not. The patient is not drowsy. Repeat the injection. So another 1 ml of injection morphine is given. Wait for another 10 minutes and reassess the pain score after 10 minutes. Now the pain score has come down to 4 and the patient is still not drowsy. Again, since the pain score is still 4, we are planning to give another shot of injection morphine. So 1.5 milligram of injection morphine is given again and wait for another 10 minutes and reassess the patient after 10 minutes. So 10:30, we are reassessing the patient. Now the pain score has come down to 1. Patient is still not drowsy, but the pain score has come down and now we are stopping with the titration process as the patient has got a satisfactory pain relief. I hope this process is clear to you. Intravenous morphine titration. So now we have given the patient, sorry.
Nothing, ma'am. It's clear to us.
Thank you. Okay, thank you. So now intravenous morphine is given in every 10 minutes interval. And now since the patient has satisfactory pain relief, we have stopped the titration. So now the patient has been already given 4.5 milligram of intravenous morphine. Suppose we want to send this patient home. What do we do? How can we send this patient home? So he had come to our OPD. We have done the intravenous morphine titration and found that the patient had satisfactory pain relief with 4.5 milligram of intravenous morphine. Now we want to send him back home. How do we do that? So we can send him home on oral morphine. How do we do that? So this IV morphine has to be converted to oral morphine.
You
And-
cannot stop the video because the first test is open.
Sorry? I'm sorry.
Can you repeat?
So, okay, so the intravenous morphine should be converted to oral morphine because we have to send the patient home. So how do we do it? So for morphine titration, it is 1:1 conversion. So when we go with the intravenous morphine titration, we usually do the oral conversion, it is 1:1. So ideally, this patient should be sent home on 4.5 milligram of oral morphine, or to the next nearest available dose of tablet. So morphine, the next nearest available dose is 10 milligram. So we'll send the patient on half milligram, that is 5 milligram of oral morphine every 4 hours. So that is how we send the patient home after the intravenous morphine titration. If we want to convert it to oral morphine and send the patient home, it is 1:1 conversion, and 4.5 milligram of IV morphine is converted to 5 milligram of oral morphine. So it is 5 milligram of oral morphine every 4 hourly, 6 a.m., 10 a.m., 2 p.m., 6 p.m. and bedtime we give double dose so that we don't want to wake the patient up at 2 a.m. and give an additional dose. So to maintain the steady dose of morphine in the blood, we give the double dose at night. And one SOS dose of morphine is also prescribed. Same dose of morphine is also given as SOS dose. That is 5 milligram is prescribed as SOS dose also. Always, as per the principles of analgesic use, prescribed by the clock, by the mouth, by the ladder and individualized treatment. So what do you mean by the clock? Always ensure the frequency. So for morphine, the patient has to be given every 4 hourly. Always prefer with the oral preparation by the mouth. And when I say by the ladder, depending upon the severity of the pain, you prefer the step of WHO analgesic ladder. So depending upon the intensity of the pain, if it is step 1, step 2 or step 3. So you always prescribe the analgesics based on by the ladder, depending upon the severity of the pain. And individualized treatment means it is for individual patient, it would be different depending upon the patient assessment. Next slide, please. Suppose the patient has come to you and IV morphine is not available with us. How do we go about the oral morphine titration? In a patient who is new to opioid, we always start with 5 milligram of oral morphine 4th hourly. And in a patient who is already on an weak opioid, suppose the patient is already on tramadol, we start with 10 milligram 4 hourly of oral morphine. This is oral morphine titration. Next slide, please. So the patient, Mr. X, who was started on 5 milligram of oral morphine every 4 hourly and SOS, he was having pain relief, satisfactory pain relief for 2 weeks. But since the last 4 days, he needed 3 extra doses of morphine per day. So 3 rescue doses or SOS dose of morphine was needed since last 4 days for satisfactory pain relief. What shall we do now? And how frequently would you give the SOS dose of oral morphine? So what does that indicate? He was needing more number of morphine doses, means that the pain relief was not satisfactory with the current dose. That clearly indicates that the dose has to be increased. And how do we increase the dose of oral morphine? So if the patient has taken more than 2 or more rescue doses in 24 hours, we have to increase it by 30 to 50%. That means the patient, if 5 to 7.5 or to 10 milligram. So the patient was on 5 milligram of oral morphine every 4 hourly. You can increase it to 7.5 or 10 milligram every 4 hourly. And how frequently would you give SOS dose of oral morphine? So I have been telling you that we have to give SOS dose of oral morphine also as the patient in between. If the patient needs rescue dose, the patient has to take. How frequently would you give the SOS dose of oral morphine? Anybody has any comments on that? Anyone want to type in the chat box? So to
4
how,
hourly, 4 hourly you said.
sorry Renuka, it was not clear. Can you please repeat
4
it?
hourly? Yeah, 4 hourly.
4 hourly is the normal dosing, but rescue doses, how frequently can we
Rescue
give?
doses.
Sorry?
No, I'm not sure about those.
Okay. So we are getting multiple responses. So to understand this or to learn more about this, we need to know about morphine. So what is morphine? So morphine, it is a naturally occurring opioid alkaloid, and it is being extracted from the opium poppy known as Papaver somniferum. So what does the generic name is Papaver, and somniferum means that it is inducing sleep. So morphine is usually extracted from the seeds of poppy plant, the straw of poppy plant, and it is legally permitted to be cultivated in India. It is permitted to be cultivated in Madhya Pradesh, Rajasthan, and Uttar Pradesh. These are the three states which has legal permission to cultivate morphine and which is being used for medical purposes. So we'll be learning in detail about the pharmacokinetics of morphine, the absorption, the distribution, metabolism, and excretion. So next slide, please. Regarding the absorption of morphine, it is a weak base, and when taken orally, it is absorbed from the upper part of the small intestine. Since it is hydrophilic in nature, it has a slow onset of action and it has a longer duration of action. And when given sublingually, the absorption rate is very low. And the buccal and gingival, the absorption, the research findings or the evidence are very variable with the buccal and gingival route. And morphine is found to have a bitter taste. So the most preferred route for morphine is the oral route. And moving on to the metabolism, morphine when taken orally, it reaches the gastrointestinal tract where it gets absorbed into the blood vessels and it reaches the portal vein. And from that, it reaches the liver where it undergoes metabolism. And it gets converted to its metabolites and they are released into the systemic circulation. So metabolism of morphine mainly occurs in the liver, but a minor part of metabolism takes place in the gastrointestinal tract as well as in the kidney. And this metabolism, it gets converted, 90% of the morphine gets converted to its metabolites, and the metabolites include the morphine 6-glucuronide and morphine 3-glucuronide are the major metabolites of morphine. And the morphine 6-glucuronide is responsible for the analgesic effect of morphine. And morphine 3-glucuronide is responsible for the neurotoxic side effects of morphine. So the 90% of the morphine gets converted to its metabolites, and the metabolite morphine 6-glucuronide is the one that gives the analgesic pain relief with morphine. So to the question, how frequently would you give SOS dose of morphine, is that morphine when taken orally, it takes around 45 minutes to 1 hour to produce its peak analgesic effect in blood. So there should be an interval of at least 1 hour between 2 doses of morphine. To make it more clear, suppose a patient was given a dose of morphine at 6 a.m. and when the pain relief was assessed at 6:30, if the patient is still having pain, please wait for another half an hour and see if there is any difference in the pain score at 7 a.m. And if the pain relief is not satisfactory or the pain score has not come down at 7 a.m., then give the rescue dose of morphine. And so such a way that there is a minimum of 1 hour gap between the 2 doses of morphine. This is for morphine to act on the body and produce its peak effect. Hope it's clear. So the patient, we have started him on 10 milligram of morphine every 4 hourly. But he finds it difficult to take it every 4 hourly. The patient has and he's Thank you. Sorry for that interruption. The patient finds it difficult to take it every 4 hourly. He feels that he is having adequate pain relief with the medicine, but the frequency he finds it difficult. He is requesting for less frequent dosing. I would request the participants to keep your side muted unless you want to say something. Thank you. So, suppose the patient is willing to take the medication but requesting for less frequent medicine intake, what will you do about it? Any comments?
Thank you.
Please feel free to interact.
SOS? Any other responses?
We can, I think,
Ma'am, what should be the dose when we're giving very early? Hello.
Yes, Renuka, please go ahead.
Ma'am, the early dose of, early dose should be how much? It should be 5 mg or 10 mg?
Sorry, Renuka, I didn't get you. Can you please repeat your question?
Yeah, we are giving the rescue dose of morphine every hour, right?
Yes.
So what should be the dose?
So, okay, I'm sorry, I didn't make it clear. So that suppose the patient is on 10 milligram of oral morphine every 4 hourly, the same dose is used as the rescue dose. So you should give the patient 10 milligram itself as the rescue dose. So it is 1/6
Right.
of the total dose in 24 hours. So
Okay.
that is, suppose the patient is on 10 milligram of oral morphine every 4 hourly, the total dose of oral morphine in 24 hours is 60 milligram, 6 doses a day. That is 60 milligram. 1/6 of that is 60 by 6, that is 10 milligram itself. So the same dose is given as the rescue dose.
All right.
Hope it's clear, Renuka.
Yes, ma'am.
Okay. So for this patient, what would be, how can we go about it is the sustained release morphine. So as you already we discussed, for immediate release preparations, it is 4 hourly duration of action. But sustained release, the duration of action is 12 hours. So for this patient who is on 10 milligram of oral morphine every 4 hourly, that means 60 milligram in 24 hours. So that patient can be given 30 milligram of sustained release preparation twice daily. So to understand this more, the preparations of morphine. So morphine is available as in aqueous solution or syrup form, in tablets form. As we already discussed, we have immediate release tablets as well as sustained release tablets. And we have injectable form of morphine available. Next slide, please. So now moving on to, we are progressing with the story. So this patient, we have started him on 10 milligram of morphine every 4 hourly. Since for the past 6 months, he was having adequate pain relief. But now he has reported to you with excessive drowsiness. And on examination, it was found that his serum creatinine was 5 milligram per deciliter. Will you do anything with the morphine dosage? So the patient is on 10 milligram of oral morphine every 4 hourly, but now has brought to you with excessive drowsiness. And the reports say that the patient has a serum creatinine of 5 milligram. Yes, Divya, you said decrease the dose. Why do you want to go the? Yes, we are getting multiple responses saying that the dose needs to be decreased. Why do you want to decrease the dose? I agree with that. The dose needs to be decreased, but why?
Because he felt excessive drowsiness and he has serum creatinine is very high
Yes.
as for normal. That's why we can decrease dose for the patient.
Okay. Thank you, Madhu. I hope I pronounced your name correctly, Madhu.
Yes, Madhav. But in certificate, my name is become like this. That's why
It's
but it's
Madhav.
Madhav. You know, Madhav, Radha, Madhav. You know,
Okay.
it's
Okay.
seems like
Okay.
yeah.
Yeah, Mother. Thank you for that response. Yes, you said it
Yeah.
rightly that the dose needs to be reduced. So why do we want to reduce the dose? To understand that more, we'll have to learn about the excretion process of morphine from the body. So morphine gets excreted from the body through glomerular filtration. From the kidney, morphine is excreted. And so what happens in renal failure? We have already discussed that the metabolism takes place in the liver and morphine 6-glucuronide is responsible for the analgesic effect. So what happens in renal failure is that this morphine 6-glucuronide accumulates in the blood and its clearance is decreased. Since its half-life is prolonged and it remains in the blood for longer time, we need to reduce the dose. Either we need to reduce the dose or we need to increase the spacing between the doses. So, or another choice would be alternate opioids, which are renally more safe. So these are the choices. So since morphine is excreted through the kidney, there are high chances of, in renal failure, there are high chances of accumulation of the metabolite in the blood. So only lesser dose is needed to produce the analgesic effect. And that too, the frequency here should be reduced. Otherwise, the toxic effects will set in earlier. So we should be prescribing a reduced dose and with increased spacing between the doses. So you can either give thrice daily or also reduce the dose. So for this patient, we have sent him, thank you. We have sent him home on 5 milligram of oral morphine 8th hourly. So we have reduced the dose and also we have reduced the frequency. So the patient was sent home on tap morphine 5 milligram 8 hourly. And after 2 months, since the disease was progressing, he was unable to swallow anything, including morphine. So what can we do for this patient? But he needs medication for pain relief, but unable to swallow anything. And he wants to be at home. What can we do for this patient? Any comments or suggestions?
No, ma'am, but I have a question. Like, if morphine dose is decreased, I mean, we are decreasing it continuously. Is it also to maintain the withdrawal symptoms? I mean, this could be a reason. that a person, if you stop the dose immediately, it can show more of the withdrawal symptoms? Here's my question actually.
Yeah. So, thank you for that, Renuka. For this patient, why we have reduced the dose is that his uh, serum creatinine is increased, which indicates that he is in for a renal failure. And there,
Mhm.
because the excretion of morphine is through kidney, if we don't reduce the dose of morphine, there are high chance of morphine being in the blood and resulting in toxic effects. At the same time,
Okay.
this patient needs morphine for pain relief. So here we are reducing the dose of morphine so that only less dose of morphine is needed for this patient at this point for pain relief.
All right.
And coming
Thank
back
you.
to your other question, usually when
Mhm.
we wean morphine, there are chances if the patient was on morphine for more than 3 weeks, it is always good to taper the dose of morphine and withdraw the drug.
All right then. Thank you.
Okay. So coming back to the question, anybody has any comments on this? How can we manage his pain at home to a patient who is unable to swallow anything but still has pain and needs to be given morphine? To understand this, we need to understand the routes of administering morphine. As already mentioned, the best preferred route is oral. The other routes include intravenous or subcutaneous, per-rectal, epidural, and intrathecal. So these are the various routes of administering morphine. So suppose we want to send this patient home. Can somebody tell me how can we send this patient home now? Any answers?
If possible, we can give IV cannula and we will use IV routes if possible.
So,
Ma'am,
thank
we
you,
can-
Father, for that response. Yes, Renuka, please go ahead.
Can it be given rectally? I'm not very sure, but still.
Yeah, so I've already mentioned the routes of administering morphine. So one of the routes is per-rectal, Renuka, and you're right.
Yeah. Thank you.
So actually we can send the patient on intravenous or sub-Q also, but the concern is that it would be difficult for the patient, a terminal patient, and especially we have to send the patient home. So the most preferred would be per-rectal. If the patient is willing, per-rectal, the same dose, the oral medication can be used per-rectally every 8 hours. So the per-rectal absorption is almost comparable with the oral absorption. So the same oral tablet can made in with a drop of water, it can be made into a paste and can be applied on the rectal mucosa. And the patient can be at home comfortable. The issue I saw in the chat box that there is advice on sublingual. I have already mentioned that the morphine has a bitter taste and the absorption sublingually is very low. So usually it is not a preferred dose to send the patient on sublingual preparation. Moving on, we have another patient. So this is another patient, Mrs. K, 55-year-old lady who was presented with CA carcinoma of the colon with abdominal pain, which is a continuous pain, and was on morphine 10 milligram 4 hourly. So she is having adequate or satisfactory pain relief with the current dose of morphine. So the doctor has asked them to replace morphine with 25 microgram of fentanyl patch. And yes, Kiran? So the patient was sent home. So the patient was asked to replace morphine with fentanyl patch, 25 microgram of fentanyl patch. But the next day, the patient reported to you telling that the fentanyl patch was replaced after 5 hours. As the patient was not having adequate pain relief, he replaced the fentanyl patch. What will you do? So we learn a bit about the transdermal fentanyl patch also. So how does this transdermal fentanyl patch act? So this patch is usually placed on intact skin without any abrasions. The skin should be intact and you should not use the shaving or some kind to remove the hair. There should be no hair and it should be placed on intact skin, because if there are aberrations, micro aberrations in the skin, it can affect the absorption of the drug. And so this patch is placed on intact skin in the body. And how does this fentanyl patch acts? So it forms a subcutaneous depot of the drug, and the drug is being released from this slowly. And this drug usually produces effective analgesia after 8 to 12 hours. So this depot starts releasing medications or the fentanyl into the blood, and it produces an analgesic effect only after 8 to 12 hours of the application of the patch. And a fentanyl patch usually lasts for 3 days. When you place a fentanyl patch, it lasts for 3 days. And fentanyl patch is recommended only for patients with stable pain. So that means that when you say a patient is on 25 microgram of fentanyl patch, it means that 25 microgram per hour of fentanyl is being released into the blood. And if the patient is having any breakthrough pain in between, we will not be able to do anything about it, because since the patch is already placed, the release will be constant. So usually for patients with unstable pain, we don't recommend transdermal fentanyl patch. And it is also available in the form of injections and also as I already mentioned, transdermal patch and also oral transmucosal fentanyl citrate. It is lipophilic in nature and is more 100 to 150 times more potent than morphine. And 60 milligram of oral morphine equivalent a day is equal to 25 microgram per hour of fentanyl patch. That means that a patient who is on 10 milligram of oral morphine every 4 hourly, that means 10 milligram of oral morphine every 4 hourly means 6 doses of morphine in a day, 60 milligram in 24 hours. A patient, if you need to convert to fentanyl patch, that patient needs to be placed with 25 microgram patch. That is 25 microgram patch releases 25 microgram of fentanyl per hour. So this would be the conversion ratio from morphine to fentanyl. So now there is another patient scenario where you have a 70-year-old man with carcinoma of the lung, and he is complaining of throbbing type of pain in right, which is a continuous pain in right front of the chest, which is scoring around 5/10. He is a non-epileptic patient and is on levetiracetam 500 milligram BD. How will you manage his pain? So please type your answers or you can unmute and talk. The pain score is 5/10. It is a continuous throbbing type of pain. And the patient is a non-epileptic patient who is on anti-epileptics. Any suggestions on his management of pain? Ideally, what would be the step of WHO analgesic ladder that we would prefer in this patient, depending upon the intensity of pain? Step 2. Yes. So step 2. Yes, you're right. Step 2, because it is mild to moderate pain, it comes, the scoring is 5 by 10. So we'll go with step 2 opioids. What are the step 2 opioids? Can somebody unmute and tell me? You have just learned it in the last class, I think. Which are the step 2?
Tramadol.
Tramadol, yes. Tapentadol. Yes, yes, yes. Thank you. Thank you for the responses. Yes, tramadol, tapentadol are all the step 2 opioids. So ideally for this patient, step 2 opioids would be the choice. But since the patient is an epileptic patient and is already on anti-epileptics, tramadol and tapentadol are found to reduce the seizure threshold, and they should be prescribed with caution in patients on anti-epileptics or epileptic patients. So I would suggest you to prescribe a low dose of step 3 opioid for this patient. So it would be optimal or good to start this patient on a low dose of morphine than on tramadol. Okay. So now, what are opioids? Opioids means the main two characteristics of opioids is that they produce their effects by combining with the opioid receptors, and their action is antagonized by naloxone. So these are the two main characteristics of opioids. So opioids, they produce their effect by combining with the receptors, opioid receptors, and their action is being antagonized by naloxone. And these opioids can be naturally occurring semi-synthetic or synthetic drugs. What are the opioid receptors? Mu, kappa, delta are the opioid receptors. Sigma is not considered as a true opioid receptor as its action is not reversed by naloxone. So I already told you that one of the characteristics of opioid is that their action is reversed by the naloxone, antagonized by naloxone. But so sigma is not considered as a true opioid receptor. So the opioids are classified based on their receptor interaction as agonist, antagonist, and agonist, antagonist. I'm not going into the details. Just opioids, agonist means they, along with the opioid, they bind with the receptor site and produce the analgesic effect, or whatever effect the opioid is producing, it will increase that effect. That is an agonist drug. An antagonist drug means that these antagonists will displace the agonist from the receptor side and will not enable the agonist to produce its effect. For example, morphine is a mu agonist. That means that morphine binds with the mu receptor site to produce its analgesic effect. Whereas naloxone is an antagonist of morphine. Naloxone is an antagonist. So what does naloxone do? When naloxone is given, it replaces the morphine from the receptor site and binds with the mu receptor site. So it will not enable the morphine to produce its effect. So that is antagonist. And some drugs are classified as agonist, antagonist, because they have agonistic action at certain receptors and they have antagonistic action at some other receptors. So now, moving on to the side effects of morphine. What are the common side effects of morphine? Anybody?
I think constipation.
Constipation.
Vomiting,
Vomiting.
drowsiness.
Very good. Drowsiness. So,
Yes, depression is also one of the reasons, one of the side effects.
okay. So the adverse effects of morphine can be classified as side effects and toxic effects. So the side effects means that those which happens with the therapeutic dose, the adverse effects that happens with the therapeutic dose is known as side effects. So even with the therapeutic dose, these adverse effects occur. That includes constipation. Around 95% of the patients will have constipation with morphine. And what you need to remember is that when a patient is started on morphine, make sure that the patient is also started with the laxative. As long as the patient is on morphine, the patient should be prescribed stimulant laxative also. Stimulant laxatives like bisacodyl, sodium picosulfate would be the preferred stimulant laxatives along with morphine. And this should be continued as long as the patient is on morphine. Now, other side effect is nausea and vomiting. So what happens? Nausea, it also occurs around 1/3 of the patients on morphine develops nausea and vomiting. But this is a self-limiting symptom. Even in intravenous morphine titration, we gave the patient an antiemetic before starting the morphine titration. So, but this is a self-limiting symptom, and this happens due to the stimulation of the chemoreceptor trigger zone. So the drugs like haloperidol, metoclopramide, domperidone would be the drug of choice, and usually this should be given to the patient for at least 3 days after the initiation of morphine. So when you start a patient on morphine, the main thing is that you should educate the patient that there are chances of developing constipation. So you should take the stimulant laxative. As long as you are on morphine, you need to take the stimulant laxative. And suppose, and also there are chances of developing nausea and vomiting, and this symptom might get, it is a self-limiting symptom, and it might wean by itself within 2 to 3 days. And for that period, you need to take metoclopramide, drugs like metoclopramide. And of course, sleepiness and tiredness are also other self-limiting symptoms. So you should need to educate the patient that the patient might feel sleepy or drowsiness, and this might continue for 1 or 2 days. But if it persists even after that, you need to be informed. And the other side effects include itching, dry mouth, urinary hesitancy, etc. So suppose the patient is on, we have already discussed all these points. So this I have already discussed. So the toxic effects, what are the toxic effects of, what are the toxic effects? Suppose the adverse, sorry?
Nothing. Please continue.
Yeah. So if the administered dose is higher than that is required for pain relief, or if the pain is not opioid sensitive, then the patient develops toxic effects. And the toxic effects include delirium, myoclonus, drowsiness, etc. So, does opioids produce respiratory depression?
Yes.
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 So, Madhav, you have been using opioids. Have you seen any cases of respiratory depression with opioids?
Yes, ma'am. I just finished my duty, and I saw a patient who have side effect like pethidine. So I think pethidine is similar to SFC, I think, opioid. So the patients feel sometimes is very uneasy to uh, take breathe. So I thought, yes.
Okay. Anyone else have any experience to share? So, actually, I have been working in palliative care since 10 years. And in so far of my experience, I have not seen even a single patient who developed respiratory depression due to oral morphine. So, that means that when the patient is given medications by the mouth, if it is given in doses, unless it is given judiciously and cautiously monitoring the symptoms and the dose is titrated orally, there are very less chances of developing respiratory depression. So the main point is that look for the toxic effects and titrate the dose based on the response to the pain. So if this is done cautiously and with under good monitoring, there are very less chances of developing respiratory depression. And when does this respiratory depression happens or compromise usually occurs when there are other comorbidities associated with this, like suppose the patient is having pneumonia or pulmonary embolism, or it is co-administered with some benzodiazepines. In such situations, there are chances of developing respiratory depression. But very less chances of developing respiratory depression when morphine is given judiciously and with caution and properly titrated, monitoring the toxic effects. Does morphine causes addiction? Does morphine causes addiction?
Yes, ma'am.
Yes.
They feel hallucination and delirium. They feel like euphoria. That's why I think they addicted.
Okay. So let me talk about the evidence. What does the evidence say? So the research says that chances of substance abuse is very less when it is used for medical purposes. And-
Very less chances, ma'am. I think
Very-
when we are using for purposely for only medical treatment, it is not addictive. It is addictive in form of taken as a heroin or as illicit drug, maybe.
Yes, yes. Thank you. Thank you, Renuka, for that. Yes, that is what the research also or the evidence says. And there has always been an overestimation of the risk of addiction. Always even the physicians are a bit confused. Like due to the risk, they are afraid whether there are chances of developing addiction, and because of this, there is under usage of the medication. And there has always been a confusion between physical dependence and psychological dependence. So, what is addiction or psychological dependence? So, according to the American Academy of Pain Medicine and American Society of Addiction Medicine, addiction is a primary chronic neurobiologic disease with genetic, psychosocial, and environmental factors influencing its development and manifestations. It has impaired control over drug use, compulsive use, and continued use despite harm and craving. And this is what is called as psychological dependence or addiction. And what is physical dependence? It is a state of adaptation that is manifested by a drug class with specific withdrawal syndrome. How many of you like to have tea in the morning? How many of you like to have tea? Like, I cannot stay without tea. How many of you really want to have a tea in the morning?
Not me.
My husband.
Hmm.
Yes. So Kiran Kiranjit says that he wants. Okay. So if you don't have a tea, what happens, Kiran? Nobody takes tea in the morning.
No, I take rarely once or twice in a month, and if I don't take, it doesn't cause any effect to me. But I guess in my family, I've seen my mother need tea at 5:30 in the morning when she gets up.
Okay.
So otherwise, she said that I cannot start my day and I feel not feeling fresh. Yeah.
Okay. Yes, yes. So we get So, okay, Dixon has told that if he misses his tea, her husband gets very irritable. Yes. So many people. So suppose one day the tea is not available. Dichan, you don't have a tea leaves at home for a day, and your husband really needs tea, and he knows that there is a tea leaves in the adjacent flat, but there is no one whom he could ask for. And suppose he is breaking open the house and getting into the kitchen and getting the tea leaves and drinking the tea. That is psychological dependence. So despite knowing that this is not the right thing to do, and the craving is so much that they tend to do it. That is psychological dependence. And as many of you have responded, Kiranjit also have responded, and Renuga has also said that some of them develops headache, some of them develops tiredness, they cannot do their day, go ahead with the day without tea. This is because the body has been used to getting tea since a long time, and you are not providing tea to the body that day, then the body reacts in the form of withdrawal syndrome. That is physical dependence. It could be in the form of headache, tiredness, restlessness, all sort of forms. That is physical dependence. So just to make you understand from that very big definition, what is the difference between psychological dependence and physical dependence in simple sentence? I hope I made some justice to it. Let's move on. So this is a comparative cost of opioids. Just to make you understand that whenever your doctor prescribe an opioid, to ensure that they do it understanding the socioeconomic status of the patient also. Because a 30 milligram of morphine cost 3.50 rupees per day. The same equipotent dose of tramadol costs around 24 to 50 rupees, and the same equipotent dose of fentanyl patch costs 250 to 400 rupees per day. And of buprenorphine patch, it is 1920 per day. And of methadone, it is 4.50 rupees. So this is the difference in the cost of opioids available in India. So this is just to bring your attention to the variation in the opioid expense part of the opioids. So when you switch a patient from morphine to fentanyl, please look into the socioeconomic status of the patient and see if the patch is affordable for the patient, or please recommend from your side to your doctor to think once more before prescribing a fentanyl patch to the patient, if it is really affordable to the patient. I think that with that, I am concluding my session. Thank you, and over to you, Arya. It's open for discussions. If you want to discuss anything, you can discuss now, or otherwise we'll move on to the case presentation.
I have a question.
Yes, Madhav, please go ahead.
My question is two questions. The question one is when we give 8 hourly with at the dose every 8 hourly dose like 15 mg morphine, is it work? Because we know that the morphine duration is 4 hour work. So is it work or not work for 8 hourly?
So ideally, if the patient renal status and liver condition is good, the patient should be prescribed morphine. The duration of action of morphine is 4 hourly. And since the morphine is metabolized in the liver and is excreted to kidney, if the patient's liver and renal conditions are good, then it should be prescribed 4 hourly if it is for pain. But if it is for breathlessness, if you are prescribing morphine for breathlessness, it would be varied. The dosage would be 8 hourly or maybe BD dosage. But in case of renal failure, usually the dosage would be, the frequency of dosing would be thrice daily, would be the preferred dosing. So,
Thank
that
you.
is-
And
Yes,
I think I got this answer.
okay.
And the second question is when we give opioid like morphine or step 3 later step 2 drugs, should we avoid about the patient's side effect or adverse effect, or we will just manage pain, which we will prefer for the patient? Adverse effect, or we will just manage the pain? What do we think? Should
Madhav, I'm sorry, Madhav, can you please repeat the question? I'm not sure whether I've understood it rightly.
I think I just want to know
Yeah.
when we give opioid like morphine, should we aware about this patient's side effect for drug,
Yeah.
or we will just manage the pain? Which we will prefer?
Yeah.
Manage
So-
pain or side effect? We will in which we will focus, manage pain or side effect?
So Madhav, if you are talking about educating a patient, when you prescribe a patient on morphine or when you give a patient morphine, we should clearly explain to the patient what all side effects should be expected when the patient is on morphine. Like the immediate side effect of nausea and vomiting, the constipation which we might have. So that is why we have prescribed on a stimulant laxative. They have to continue with that. The antiemetic should be continued for 3 days. And sleepiness and drowsiness are likely to happen, but if they are not settled in 2 to 3 days, you need to inform us. It is during that time that we need to be rechecking on whether the pain is opioid sensitive or whether the dose is on a higher side. So I would say we should balance this both. We should explain the patient very well what are the side effects to be expected when we prescribe morphine, and also we should have a thorough knowledge of how to balance this. And of course, morphine is a wonder drug where if we use it judiciously, it can give very good results to the patient's pain and improve the quality of life of the patient. I hope I answered your question, Madhav.
Yeah, thanks, ma'am.
Okay. So
Okay, is there any more doubts?
I think we can start with the case presentation, and if there are any doubts, we'll take it during the case discussions. I hope we can go ahead with the case presentation.
I think our trio is ready. Who is going to present, Lipi, Madhav, or Martina? Madhav, are you presenting?
Yeah, presenting. Thanks for
Please
this
go ahead.
opportunity. Thanks for the opportunity to present my presentation. My case presentation done by Sri. Oh, sorry. Okay. Patient details. The patient is a 16 years female patient, diagnosis synovial sarcoma of oropharynx. Next slide, please. Presenting complaints, pain, weight loss, nothing by mouth, PEG tube, swelling of nose, difficulty sleeping, cannot swallow. History of illness, 16 years old female with sarcoma of oropharynx since before 2014. First excision of tumor was done in 2014 in Dhaka, followed by 6 rounds of chemotherapy. Recurrence in 2020. 2 surgeries done in Vellore, India in 2020 and 2022. Easy tube for feeding and for the breathing placed in 2021. Examinations. Patient appears very ill. Visible swelling of nose, pain, some relief with BDS morphine, but still not controlled. Trach and PEG tube is in place. Patient weak but able to ambulate. Treatment and significant investigation. Biopsy confirmed cancer in 2014. Surgery in Dhaka in 2040, 2024, sorry.
It's 2014.
2020.
Oh, I don't know, wait a sec. So 2014, actually.
Oh, sorry.
Yeah.
Yeah, I just. Surgery in Vellore in 2021. Surgery in Vellore in repeated 2023. Occasional hospitalization at LAM for anemia and
Maybe. Mhm.
next slide, please. Psychological, psychosocial aspects. She has a caring father and mother. Her mother is a teacher, is still working, and her father is a primary caregiver. She has a brother and sister in school. She has a Paka house. It means building. Looks like building, but not.
Cement.
Yeah, house, and and is well cared for. Also, her parents are sad and overwhelmed. Patient appears sad and depressed. She is unable to speak because of her communicate with. She can communicate with writing or sign language. Medications. Afidatamab 20 mg OD. It's a chemotherapy. And carvedilol 3.125 milligram BDA. Genonate OD. Morphine 15 mg BD. Tranexamic acid taking PRN when she had bleeding. Mom taking PRN for constipation, cough medicine, PRN. Main concern, uncontrolled pain due to the spread of cancer, swelling of nose, sleeplessness due to pain, weight loss, constipations, depressions, caregiver strain. Summary. 16 years old with recurrent cancer following 3 surgeries with a track and PEG tube in place. Now with significant weight loss and uncontrolled pain and caregiver strain in family. Discuss point. how can we better control for her pain and swelling? How can we prevent constipation? How can we promote good rest at night? How can we, how can the patient and family will support mentally and emotionally? Thank you for
Thank you, Madhav.
Yeah, so thank you, Mother, for that patient story. And it's open to for discussion to the participants. So we have gone through the session now. I would like to get recommendations from the participants on how can we better control her pain and swelling. Okay. So, yes, Kiranjit wants to know the pain score. Madhav?
Please, I'm sorry for this, but the patient pain scores like 7 or 8, but didn't mention it's sorry for this. But the patient pain score is 7 to 8
Okay,
out of 10.
all right. So, what I would request you, since you have learned so far the management of pain, assessment of pain. So when you are presented with a symptom of pain, the PQRST of pain should be clearly mentioned. Like where is the pain, the site of the pain, the nature of the pain, whether it is radiating, what is the score of the pain. So that PQRST of pain needs to be mentioned. This is for the purpose of, like, whenever you record this, you will be able to understand whether the medication has helped the patient or whether you need to increase the dose of medicine or you need to decrease the dose of medicine. That scoring is very important when you do the pain assessment. So this patient, according to me, as I understand, the patient is on 15 milligram of morphine twice daily. But Madhav, I don't understand whether it is an intermediate release, it's an immediate release preparation, or why was the patient on BD dose of morphine, like twice daily dose of morphine? Show the medication slide. So first of all, thank you for bringing this patient story itself, because it is very much suited for the session that was done and will bring in a lot of discussions to the team.
Right.
Yes.
So I can answer a couple. I'm Sarah. I'm helping supervise this course. So I can speak a little bit as to the morphine we have in Bangladesh. So the 15 milligram is not extended release. It's the quicker acting one. And that's generally how doctors prescribe here, is either twice a day or 3 times a day. But we have physicians that are taking the course now. So they're also learning a bit more about morphine, that there's no limit on, that the goal is to control pain. It's not, we don't need to limit the morphine according to the pain control. So that's the situation here.
Thanks. Thank you, Sarah, for that. And so, as you have learned now about morphine, more about morphine, the ideal prescription, what do you say, Madhav? What would be the ideal prescription for this patient now after the learning? What do you think would be the ideal prescription?
I think I think the ideal patient will say according to time 4 hours. So
Yeah.
ideal patient
So it
one
would
point
be-
five.
Yeah, it would be like after the total pain assessment or proper pain assessment, if the patient is being started on morphine for the first time, like the patient was not on opioid at all, we'll prefer to start the patient with tap morphine 5 milligram 4 hourly. Would be the ideal way to start off. If the patient's liver and renal conditions are okay, the patient can be started on 5 milligram 4 hourly. But if the patient was already on step 2 opioids like tramadol, ideally it would be good to start with tap morphine 10 milligram 4 hourly. And as I already mentioned, there is no ceiling effect for morphine. You can increase the dose of morphine, but the only point where you need to look into is watch for any toxic signs and see how the response to pain is there. So keep these two things in mind and you can titrate the dose. Suppose one dose is given and after 1 hour, the patient is not having adequate pain relief, you can repeat the rescue dose. So first we need to optimize the dose of morphine given to the patient. It should be a 4 hourly dose because the duration of action, as we learned, is only for 4 hours when it is the immediate release preparations. So we should be prescribing like that. So that is by the clock. That is what we mean by saying by the clock. And so since you have mentioned that the pain score is 7/10, so by the ladder, it is step 3 opioids would be suitable for this patient. And when you start on opioids, always keep in mind that an antiemetic should be given for at least 3 days. There are at least 1/3 of the patients are likely to develop nausea and vomiting. So first, at least first 3 days, provide the patient with metoclopramide 10 milligram thrice daily for 3 days. And as we learned, constipation, the most common side effect of morphine is constipation, and which is a long-lasting side effect. And the patient should be ideally started with stimulant laxative, either bisacodyl or sodium picosulfate would be the ideal laxatives to be started with morphine. And as long as the patient is on morphine, you should prescribe the patient on a laxative. What is MOM, Madhav? I don't understand what is MOM.
The full abbreviation in is milk of magnesia is also kind of
Oh, that is milk of magnesia.
Yeah.
Okay.
Milk
So,
of magnesia. So we can short form we Bangladesh say young syrup.
okay.
So I mentioned it in MOMs.
Okay. So the first line would be stimulant laxative. So, and that should be given regularly. It's not PRN dose. Tap, bisacodyl, 10 milligram HS dose. It should be given regularly as long as the patient is on morphine. So that is and I hope that answers your next question. How can we prevent constipation? So a patient on morphine should be started on laxative. Otherwise, the patient is very much likely to develop constipation. And once the pain relief is improved, the patient will be able to sleep well. That is what we anticipate. And of course, the patient as well as the family is going through a very difficult situation. And I understand your team might also be feeling really stressed. There's a 16-year-old girl who's suffering so much, and your team is helping her so much. I think this would be some inputs which you can add to improve the quality of care that you can deliver to the patient. Optimizing the dose of morphine, adding laxatives, and like optimizing the dose of morphine is like titrating the dose, monitoring the toxic effects and the pain response, and adding laxatives. This would automatically improve her sleep and she might get better rest at night. And once this physical component gets tackled better, then we'll need to look more into the psychosocial issues of the family and what the family is going through and try to support them and ensure them that you are there to take care of them as long as they need. These are my suggestions. If any of the participants would like to add something more, please do it.
Please respond. If you need any further clarifications, you can ask to our faculty.
Madhav, I'm not sure whether you are satisfied with the reply that we have given you for your discussion points. If you have any more queries, you can write to us also to help you move forward with this patient.
No, ma'am, it's a very good for suggestion, and thank you for this suggestion. Actually, you said well that we can give legislative for the starting 3 days or 5 days or 2 days, but regularly.
Yes.
But we use it parents, so it's very we cannot prevent constipations actually.
Yes, yes.
If
It might
we
not be sufficient, yeah. Because, yeah,
so it's a very good suggestions. Thank you for this suggestion, and I'm always satisfied because you work with 10 years alone, so you have a lot of experience. I just start palliative care for 2 months, like, so I have a little experience. So I am very satisfied with your suggestion. Thank you, ma'am.
Yes. Thank you, Mother, for that. And that means that there is a long way for you to go forward and help the patients. You have already started with that. So we are there to support you. If at all there is any need or any questions, please do write to us.
Okay, ma'am.
Any more questions or anybody wants to discuss anything? If not, I think we can wind up the session.
Okay, I think there is no more doubts. Can we wind up the session? So first of all, I thank I thank our faculty, Mrs. Amirtha Thampi, for the wonderful session. It was very interactive. I thank you, our trio, Madhov, Sara, and Martina, for the wonderful presentation. And I thank all of you for for being attentive. We will see you next day with yet another session of FCPN. Till then, goodbye.
Bye. Take care.